She then oops, sorry, recording in progress, of course. So for everyone, we're recording this. And then Dr. Rodriguez completed her neurosurgical residency at Wake Forest and her fellowship at City of Hope. And, you know, during her neurosurgical training, she obtained several awards, including the Neurosurgery Research Education Foundation Research Fellowship, a CNS Leadership Fellowship, and so on. Her main interest is in the use of laser thermal ablation for brain tumors and understanding the tumor immune microenvironment. She is a board certified neurosurgeon, and she is the director of neurosurgical oncology at UAMS. And she's, you know, working to bring novel therapeutic strategies and trials to Arkansas. She has a laboratory that investigates brain tumors at the Rockefeller Cancer Institute, and we are going to hear today about molecular biobanking for brain tumor precision medicine. We're really happy to have you. Please take it away.
Thank you so much. I really appreciate the invitation as well. I'm going to be talking today about molecular biobanking for brain tumors, but I will say that obviously I'm a surgeon scientist, so a lot of the way I'm going to talk about this is through my patients and what I learned from patient scenarios, and it's really clinical translational. And then hopefully by the end of it, you will be convinced that combining genomics and cancer research models may be the way to go for precision medicine.
So the audio is very low. Is it for me only? I'm not sure.
Yeah, her audio just dropped significantly.
It suddenly went super quiet.
Hear me now?
Oh, now it's back.
Okay, is this better?
Yeah, perfect now.
Okay,
Yes.
Thank you. Okay, here are my disclosures. I'm going to be reviewing the role of the neurosurgeon throughout this talk. So obviously, from my point of view, when I take someone to surgery, the main thing is to provide a diagnosis and then also to have symptom management and improve survival. And then we'll talk about how that relates to developing research models and precision medicine, as well as addressing disparities. When I started at UAMS, there was not a brain tumor biobank, and that's something that I developed during my time here. And so this is a paper that my lab wrote. This is Dr. Dalig, one of my postdoc fellows. And we wrote about how do you develop a brain tumor biobank and what the purpose is. Can you hear me or?
Hi.
Oh, yeah, we can hear you fine. I think we had someone unmuted. Sorry about that.
I'm so sorry. Okay. So this is a schematic detailing what happens in the operating room and how important it is, the role of the neurosurgeon specifically. So oftentimes we deal with some brain tumors that are quite heterogeneous. And so if you can see in the panel A, this was a tumor that you can see on the MRI largely was not enhancing and had a small foci focus of enhancement. And the majority of the tumor was low grade. And then that small region was high grade. And the highest grade region defines the diagnosis. So it's very important that as a neurosurgeon to take those things into account and be sure to provide regional tissue that's important for the diagnosis. The other thing is I'll talk about next generation sequencing. Brain tumors are unique in the sense that molecular markers are now required since 2016 in order to diagnose many of primary brain tumors such as gliomas. And the 2021 update has required more molecular markers be used. But for precision medicine, we have routinely integrated next generation sequencing into our treatment paradigm. And we'll talk about the use of DNA as well as RNA transcriptomics. And then from the research side, regional tissue harvesting has a lot of implications in regards to which type of cells are in the microenvironment, as well as when you're creating patient-derived models, do you have viable tissue? Are you extracting parts of the tumor that have treatment change or stem cells, enriched in stem cells. So this becomes very important. And how long does it take to get from the operating room to the research lab? And does that time and the processing of the intraoperative tissue, does that affect your outcomes? So this is our surgery workflow. Preoperatively, we do approach all of our patients and ask them if they're open to consenting for our tumor bank. We also consent for next generation sequencing, and we do use glialin, which is intraoperative fluorescence, for our GBM patients. And sometimes we also do intraoperative brachytherapy, which is gamma-tile. So basically intraoperative radiation seeds. And so these are all considerations we think about preoperatively. And then when we do surgery, you have to choose multiple different pathways. Some people, we can do a traditional craniotomy and resect the tumor, but there's different approaches depending on what the situation calls for. And then once we are obtaining tissue, first and foremost is sending the tissue to pathology to get a diagnosis. And then also we think about research. And one thing that we do here routinely now, we were part of a trial called 3D Predict, is that we actually, for our high-grade glioma patients, we send for ex vivo functional precision medicine assay where we're screening drugs based off of intraoperative tissue. And then post-operatively, we obviously want to get a diagnosis, but we also hopefully can provide precision medicine for a portion of our patients. So this is an operating room. I'm not sure how many of you are clinicians versus scientists, but a lot of people don't actually see what an OR looks like. So this is an operating room where I am actually using an exoscope, and you can see on the screen, you can see this pink area. This is actually a recurrent GBM where we use an intraoperative fluorescent dye. So you can see the tumor glowing. We actually use a special sort of surgical device to resect our tumor. It's called the NICO device. We prefer that here when we're doing research specimens and certain minimally invasive techniques. But the reason is, if you see, there's a little light on this and there's a cooler, and we actually can preserve a certain temperature while we're actively resecting tumor. And that will become relevant later in the talk when we talk about research models. And then we also do high-level intraoperative navigation, where we're mapping out cortical tracts and making sure that we're not going to cause neurologic deficits. So for research purposes, obviously intraoperatively, this is a high-grade glioma. We are working, the surgeon and pathologists are working to make sure that we have diagnostic tumor. We also do use, as I mentioned, different techniques to preserve tumor tissue while we're resecting. And in this case, you can see little chunks of tumor in the tubing that will ultimately go into a sterile device, and that we can potentially take to the research lab or send to pathology if needed. And then typically, this is a little container that we extract our tumor tissue and actually coordinate with our research staff to go to the lab. So traditionally, a lot of times you may get a tumor from the lab, and you can see in the upper right-hand panel, you see just a chunk of brain tissue. But I did mention that oftentimes we do like to start the mechanical dissociation intraoperatively, and that's with the NICO device. You can see we get these little tiny chunks of tumor. For certain techniques such as single cell sequencing or organoid modeling, sometimes having mechanical dissociation will decrease what you're doing in the lab, and that can actually decrease time and help with certain assays. And then there are various digestion protocols, and then you can generate cell cultures, 2-dimensional or 3-dimensional cell cultures. We also are very much interested in these organoid models, and you can see here this is a high-grade glioma organoid. You can see it invading over time. This is obviously a video, but it's been truncated. And this is where we minimally disassociate the tumor with chemical disassociation, just as a mechanical disassociation and growing in certain media. And then definitely want to give kudos to the people in my lab who work with the research workflow in the biobank. So again, the most important thing is we only would send for research if we have diagnostic tissue. So we definitely would not want to send if we can't get a diagnosis. How does this relate to precision medicine? So first of all, what is precision medicine? Typically a person comes in and they get standard treatment. So in the case of, say, high-grade glioma, you come in, you get surgery, you're getting radiation and temozolomide. That's the paradigm. However, we do know that not everyone responds the same to the treatment. So precision medicine takes that into account. Well, what if we can stratify patients and provide the best treatment for that person? And hopefully then they could live longer. But what about functional precision medicine? And I know this is a unique group who is interested in functional precision medicine, but basically the concept is not necessarily new, in which you directly take tumor tissue and test drugs on tumor tissue in the context of cancer. And I usually tell people, if you think about one of the largest precision medicine trials, the NCI match, wherein they identified actionable DNA mutations and a wide variety of solid tumors, and then gave the person that targeted therapy. And if you look at the different post hoc analysis that are coming out from that trial, and some of which have already been published, you can see that on average, less than 30% of patients with an actionable mutation that were given that drug had clinical response. So that calls into question, how do you really predict drug response? It's not simply, hey, you have an actionable mutation, I give you that drug, it's going to work. Because it seems like 70% or more of patients, that paradigm doesn't hold true. So this is just how we use it in a clinical side. So for example, for us, we use the 3D predict assay, which is basically for high-grade gliomas. In this context, what we do is we're taking out tumor and we send a piece of tumor tissue and we ship it to a company that will actually screen drugs. They will generate spheroids and give us a report within 7 to 10 days. Oh, sorry, so this is an example of a report. They screen actually up to 12 drugs. Not this patient doesn't have all 12 drugs listed, but this is just an example of a clinical report that then the neuro-oncologist can use to think about therapeutic options. And so how does this work? How has this worked clinically? So this is actually looking at how we can potentially predict who responds to temozolomide. And I mentioned for high-grade glioma patients, that's the arm you're gonna get. You're gonna come in, you're gonna have surgery, chemotherapy is gonna be temozolomide, and you're gonna get radiation. But can we perhaps do a little better job at predicting responders? And so this was recently presented at ASCO, and what we were interested in was looking at people who had response by their functional precision medicine assay versus those who were thought to be perhaps non-responders. And you can see that in the people who were predicted to be responders, they seem to live longer. What is interesting is that clinically we use a biomarker to predict who's a responder or not. And a certain group of patients with this unmethylated MGMT promoter, typically we predict, well, it's they have an unmethylated MGMT promoter. They are going to have a silent MGMT protein. They're not going to be able to reverse the DNA damage caused by temozolomide, and therefore they aren't going to be responders to the therapy. So they you can see in this group, there were still some patients that, even though they were by a clinical biomarker, were thought all of these patients should not be responders. There's a portion of people who were responders by their assay. And then if you look at their progression-free survival, they're living much longer. So they're living 11 months longer, or have a progression-free survival of 11 months, opposed to the other group, which is 5 months. And so that is actually really interesting. One thing about this assay, though, is it requires surgical tissue. And you can see that this is a spheroid-based assay. And so to the right, you can see this spheroid that formed in a typical way. But then there are some groups of patients that maybe they've had treatment change, or maybe their cells are senescent, and you can see that they don't form spheroids, and you may not be able to get the readouts for this assay. So another thing that we've routinely started to incorporate in our paradigm is next generation sequencing. And so this is actually the first patient I ever sequenced. This is a young woman in her 30s who came in with a head and neck cancer that unfortunately actually had perineural spread, and then it on her trigeminal nerve, which is the nerve that does sensation to her face, and then it started to move back and grow towards her brainstem. And that's a very serious, horrible problem. And then eventually she had leptomeningeal spread, which is when the cancer gets into the spinal fluid and then spreads throughout the brain and spine. And so she had a SMARCB1 deficient sinonasal carcinoma. That's a very rare tumor. And at the time that we wrote this case report, it was newly classified. The SMARCB1 mutation gives it rhabdoid features. And what I will always remember is that the patient ended up dying before we published the report. So I had to call family and ask permission. And the mother of the patient asked me, well, why didn't this test help her? You know, I did the sequencing because I thought maybe this would help her. And unfortunately, she had no actionable mutations. And we weren't able to really find a therapy to help her. And the mother asked me this question. I tell people this was very inspiring to me to start thinking about, well, I do want to use next generation sequencing and genomics to help people. And how do we actually do that? Especially in a case like this, where you don't have a necessarily an actionable mutation. So we'll come back to that theme. And then after this patient, we started sequencing all of our tumors, and we'll see later on how having a cohort of patients is actually better than just sequencing individual patients. So I'm going to go through a couple of cases just to highlight how the clinical translational nature of my work, and also how my patients have inspired my research. I put a little bit of caution tape here just to specify that at UAMS we are tend to be a little bit more aggressive than maybe some other places, obviously keeping in mind what the patient wants and also not causing any neurologic deficits. So this is a patient, if you see on the far left, they have an enhancing area in the pons or the brainstem, and this is a recurrent GBM. And when we talked about it in our tumor board, it was actually discussed, well, let's go ahead and do surgery. So this, I did surgery.
Analiz, I'm very sorry, but the audio went out again just now.
Oh, thank you. Okay, can you hear me again?
Try again.
Can you hear me now?
Now, perfect. Now it's back.
Okay, I'm sorry. Thank you for letting me know. So this patient ended up having a resection and ended up living longer than I expected, and thankfully did well and didn't have further neurologic deficits. So this patient was someone who came in with seizures, found to have these little spots, multiple spots, enhancing areas in the brain. But he also was just diagnosed with renal cell carcinoma. So this is a patient we're not sure, is this metastasis or is this a primary high-grade tumor? So we performed a biopsy, and unfortunately, he had a lot of bleeding. So We kept sending tissue to the pathologist. The pathologist said, I can't see anything definitively that's neoplastic. On my end, though, he ended up having too much bleeding and I had to stop sending them tissue at a certain point. The final histopathology came back as mild glial proliferation with infiltrating atypical cells. That doesn't really help us, but what is very interesting is that we send next generation sequencing on all of our patients. This patient ended up having a TERT promoter mutation, and that led us to actually diagnosing him with GBM. So this one, the histopathology did not make the diagnosis. Actually, the diagnosis was based off the next generation sequencing. However, those current methods take about 2 weeks to return. And unfortunately, his tumor grew in the interim time and he ended up opting to not have definitive resection. Also, this isn't in a great location. This is in the motor area. But that kind of inspired us to think about, well, that takes a long time. 2 weeks is very long. And for these aggressive tumors, that sometimes is not a good time scale. So one thing that we became interested in is some of the newer sequencing techniques, such as long read sequencing or third generation sequencing. And for those of you familiar with that technique, basically you can read a DNA strand and you can also get methylation information as well without doing, for example, bisulfide treatment, etc. You can just read a naked DNA strand and read where there are methyl groups, and that also gives you epigenetic information. So in this paper, what we did is we actually used Cas9 to cut out certain really important biomarkers for brain tumor diagnosis, MGMT, as well as the IDH genes, IDH1 and IDH2, to identify potential mutations. And we saw that, thankfully, the technique that we used was comparable to currently used techniques such as Illumina sequencing. And then also the MGMT biomarker is something that we use clinically, in which we're looking at the MGMT promoter region, and we're estimated whether or not that gene is silenced based off of the level of methylation. However, it's not standardized which CPG areas are actually assayed. It's not a standard, and everyone's sending, potentially different assays and looking at different regions. But with this long read technique, you can actually read along a good amount of both the intron and exon, and you can get this beautiful feedback in regards to the methylation. So that is a really hopeful in the future. So ideally, fresh tissue is used for this advanced long read sequencing. However, you can sequence DNA, RNA, and also get epigenetic information back. And this, if you can improve protocols, this could potentially lead to diagnosis on the same day of surgery. And there is a group in Norway that has shown feasibility of doing this the same day of diagnosis and looking at various molecular markers to diagnose brain tumors. I hinted earlier that brain tumors are unique primary brain tumors and requiring molecular markers. So this is just an example from the updated WHO 2021 guidelines. And you can see now our neuropathologists have to deal with this to diagnose. It's not necessarily based on histopathology alone. So here they're going through all these different mutations and an algorithm to determine what the brain tumor is. And therefore, integrating sequencing into our current workflow will be very important down the line. So in this case, this is a woman who came in and she had a seizure. She had on the far left, this is her index imaging, where she had just a little speck of enhancement and the rest was non-enhancing. I took it out, and so in the middle you can see this little area of where I took out that region, and she got the standard therapy, radiation chemotherapy. However, she comes back after that and she has these little nodular areas of enhancement around the resection cavity. And this is like when it becomes a little tricky. We think, well, her tumor is coming back, but she also has radiation changes. And so for this patient, I used that intraoperative fluorescent dye to help me try to differentiate between what areas are treatment change and what area are actually tumor. Because again, like I mentioned, we send off tissue for functional analysis. And so again, this patient, the gliolin, was actually helpful to try to help me differentiate what is just treatment change versus what's tumor. And we were able to send 3D predict and actually find, identify a potential target for this patient, even though she had a very small amount of recurrence. And you can see that's just a very small region. So this patient, she is a 60-year-old female, and she came in with melanoma that she had diagnosed about 15 years prior to coming to see me. She never got chemo or immunotherapy. I mean, this was 15 years ago. She had a little spot on her back cut out. The lymph nodes were negative. She never thought anything about it. She comes in with confusion and weakness. And I know many of you are not radiologists, but you can see this MRI. You see all these little balls, white balls in her brain. Those are all brain metastases. So she comes in with 15 brain metastases, one very large one smack dab in the middle, kind of deeper in the brain, which is a harder location to get to, but that was what was causing her weakness. Of note, her CT chest, abdomen, pelvis was negative. So she doesn't have mets anywhere else, just her brain. And we did a skin exam, and the dermatologist said, well, I don't see anything on her skin. So we needed tissue, as well as we also needed to help her neurologic deficit. So thankfully, I did a minimally invasive technique where I was able to get that large, deep lesion. She has all these other spots on the brain, and she ended up having a BRAF mutation. So she had a targetable mutation, and she had stability for over a year. So and she got radiation. Of note, she was from a rural area, so I used a minimally invasive surgery. She got radiated while she was in the hospital about 2 to 3 days later, and then got sent home. So we learned a lot from this case that, it helped us to use the minimally invasive technique because she was rural and she was able to get radiated within a short time frame. And then also, we were able to find an actionable mutation, which was very rewarding for her and provided her with disease stability for over a year. But this is just one of the patients that also has helped in regards to helping us understand research models. So this is in collaboration with Dr. Vasquez's group, where her lab was interested in looking at matched patient tumors and cell lines. And they looked at the cancer cell line encyclopedia, as well as TCGA, and try to look at what pathways are upregulated or downregulated in cancer cell lines versus primary tumors. The only issue is that the CCLE and the TCGA are not matched. So this is just a cohort of cell lines, and then separately, the TCGA is a cohort of cancer patients. But thankfully, this is an example of one of the brain tumor samples we were able to give to the Vasquez lab. So we generated multiple cancer cell lines from our patients, and we also have sequenced a primary tumor. And this is single cell sequencing data looking at the primary tumor versus the actual cell line and trying to understand, well, how does the tumor change once you do in vivo cultures, or excuse me, ex vivo cultures. So this was really interesting work and something that we hope to continue to really understand how things change once you start modeling them. So this patient, I'm probably going to skip just in the interest of time and go to this patient. So this is a 37-year-old woman who came in with a high-grade glioma that she had taken out over a year before she came to see me. thankfully, she has a really good functional status, but again, you guys don't have to be radiologists to see she has a huge spot on her brain. Unfortunately, when you have a large tumor and it's a recurrent tumor, you don't qualify for any clinical trials. So she was shopping around asking for clinical trials. Her tumor is too large, and so she didn't qualify for any trials. Her functional status is pretty good, and she was young. So I told her, you know what, I'll take you to surgery and take out as much as I can. And then also she was rural, and we put in some intraoperative radiation seeds. And so you can see that this is actually, these little wafers actually have radiation seeds inside, and we lined the cavity with radiation. But one thing, her first surgery was done in another hospital, but I went ahead and requested that pathology block and sequenced it. And I saw, well, this is just to show you guys how the tumor changes over time. And so this is her first tumor. This is a clinical report from Tempus, which is a company we use for next generation sequencing. And you can see her tumor mutational burden is 4.2. Now, when I did her surgery, this is what it showed. Her tumor mutational burden is now 62. And you can see how her tumor has changed. So I use this case as an example of, I tend to think that we should sequence at each surgery for some of these heterogeneous tumors like high-grade glioma, and that basically the tumor is not the same. Now that it's come back, this is a completely different tumor than what she had before. So from that surgery to how long she lived, she ended up living 8 more months. And with a recurrent GBM of that size, it was like 6 centimeters, very large. I think obviously if we hadn't done any intervention at all, she would end up dying within probably 2 to 3 months. And the question is, well, is 8 months more survival worthwhile? And a lot of people ask me this. I think it's a philosophical question, but I always tell people, you know, I really discussed with the patient what she wanted. She was young, she wanted everything done. And thankfully, a month before she passed away, she was still in good enough health to go to New Orleans and have one final Mardi Gras. So I always tell people, I do think it's worth it, but it's definitely a discussion to have with the patient. So this patient is someone who was a 25-year-old male. He has this horrible scan here. You can see the enhancement all over. And this is after failing an immunotherapy trial at another location. So I've known him for years. He had a low-grade tumor that evolved into a high-grade tumor. And then he went to another hospital outside of a state to enroll in an immunotherapy trial. Unfortunately, that failed, and he got that scan, and they told him, well, there's nothing more to do. You can go to your first neurosurgeon and see if they're willing to debulk you. So I did. I debulked him, and we did another radiation treatment, one of our special protocols here for recurrent patients. And then I also did send 3D Predict, because I was like, well, we just started sending functional precision medicine assays, and he was interested in trying anything. And I will say that he had a drug identified based off of those results, and he had brief stability to even possibly improvement, if you can see the how it looks like things kind of shrunk down a little bit. And this was very exciting. But I use this case to kind of highlight combining genomics with functional information. And so in this case, this patient had next generation sequencing, again, something we do every time. And our neuro-oncologist was like, okay, they have this CDKN2 homozygous deletion, so perhaps they would be responsive to a CDK4 inhibitor. Not really many trials or information about how that works in high-grade glioma, but the functional assay shows that this patient had a moderate response to this CDK4 inhibitor. And so that's what our neuro-oncologist ended up choosing by using both of these assays together. And he had some brief stability, but of course, this ended up coming back, and he ended up passing away. But for that brief period of time, we were very excited. And the other thing that we learned is that we can use biopsy cores to send functional assays. So even very small amount of tissue, we're still able to generate spheroids and test drugs. So again, functional precision medicine, not a new concept, but can be very, I think it's having a re-emergence, because now we're getting way better at culturing cells. We have genomics, we have many more drugs than maybe we did 20, 30 years ago. So this is the last patient that we'll review. And this is basically a patient that has really inspired a lot of work in my lab, and specifically in functional precision medicine. So this is Jacob. He has, his family has given permission for us to de-identify him. You can see a picture of Jacob. This is when he first came in, young, healthy, 24-year-old, coming in with this headache and this large tumor. Of note, he had colon cancer when he was 3 years old, so that was a little strange, and took out this tumor. He ended up getting chemo and radiation. But unfortunately, just 3 months after I took out that tumor and he got his chemo and radiation, he comes back with this. So you can see here on the left-hand panel, you see there's recurrent tumor right near where I did surgery the first time. But if you see in that yellow circle, another spot on the other side. So there he has a small dural-based new spot that our radiologist called me about. And I was like, man, I think you're right. I think that probably is tumor. And I went ahead and took out both areas. And this is that little dural-based mass. You can see it's under 2 centimeters, so under 1 inch, but it was GBM. And then I was like, oh my God, this is terrible. He had recurrence within 3 months and it already moved to the other side of his brain. Like, this is a dire situation. One thing though is that we send next generation sequencing on these patients, and we always send a matched normal sample. And so we were able to identify that he had a cancer predisposition syndrome, which really helped his family, and we sent them to genetic counselors. So he ended up having Lee-Fraumeni syndrome. He did not know that, even though he had a childhood cancer. No one in his family knew this, and that's very important. So we're very happy that our next generation sequencing can help families in that way. And then the other thing about Jacob's tumor is similar to some previous cases where I showed you my first patient that I ever sequenced, he didn't have any targetable mutations. So we sequenced him, but we're like, no, that didn't really help me clinically. He doesn't have the BRAF mutation. He doesn't have the CDK2 homozygous deletion, some of these other targetable things I showed you earlier. And he's 24 and wants to do everything possible to live. So that inspired us to work with multiple labs. Dr. Vasque is a scientist who works in pediatric tumors, but does a lot of things with comparative transcriptomics, so RNA-based genomics to try to identify targets. And then Robert Oaf is one of my collaborators here. Our labs were interested in GBM and organoid modeling. And then Megan Reed is now a postdoc fellow in my lab. At the time of this paper, she was actually a PhD student in Dr. Oaf's lab. And so this patient, he told me that he wanted everything done, and as long as surgery doesn't hurt him, he wants to live as long as possible and get aggressive treatment. So you can see he ended up, even though having a very aggressive tumor, ended up living over 2 years. You can see a myriad of different treatments that he got. If you know what some of these treatments are, immunotherapy, EGFR inhibition, mTOR inhibition, a bunch of different therapies. So going back to his first tumor, one thing that was kind of interesting to us is that our neuropathologist was like, yes, this is a GBM, but you know, it's kind of weird. I see some areas that are ependymoma, and that's like the center panel. And then to the far right, I see some features of pleomorphic xanthoastrocytoma. So we kind of knew this is a strange tumor. It's not, it is a GBM, but it's a funny GBM. And then we worked with Dr. Vasquez's group to actually analyze this on an RNA-seq level. So this is a tumor map analysis where each dot represents a patient's tumor. And these are various tumors from patients of all ages and various cancer types. And then you kind of make a Google map showing how similar the patient's tumor is to others. And you can see that no tumor actually had greater than 95% correlation with this unique patient. And the top 6 tumors that correlated with our patient were not always GBM. Sometimes it was a ependymoma, and sometimes it was a lower grade glioma. So we kind of knew, wow, this is a unique tumor. And so we decided at this point, Jacob was getting a bunch of treatments and wanted to live. And what we were thinking is, okay, we'll send out his RNA and get an idea of what potential targets we can identify based off RNA analysis. And then once we have those targets, maybe we can go back to the lab. We have his tissue, test them on his tissue, and potentially come up with a treatment plan. So this analysis is called comparative transcriptomics, where you take one person's RNA and look at gene expression outliers. And what you're looking at is different pathways that have FDA-approved drug targets along the pathway. And then you are comparing your patients to compendium of other patients. So to the far left, this is looking at 12,747 cancer patients, all types of cancer. Jacob is in red. And you can see he has like pretty high levels of STAT1 and STAT2 compared to all these other cancer patients, but he's not quite an outlier. You have to be in the yellow zone to be an outlier. And then we decided, well, what about looking at the GBM patients? This is from TCGA data. What about looking at that? And you can see, okay, comparing him to GBM, he is an outlier in that STAT pathway. So this is when we decided, okay, well, thankfully we have a biobank. We have Jacob's tumor, and we generated cell lines and organoids from him. And then we have other patients as well. And based off of other patients that we have been obtaining a transcriptomic data for, we identified their potential theoretical targets. And you can see one person is MDM2, another person is JAK1. We thought, well, this person also could potentially be targeted in theory along the JAK-STAT pathway as well. And let's just see what happens. Let's actually use this tissue and find out when we give this drug ruxolitinib that actually targets the JAK-STAT pathway, see what happens. And of course, we did some RNA sequencing of the associated cell lines from these patients. And again, you can see Jacob's tumor, which is 1, all over the place. His associated cell line is just not classic for just a run-of-the-mill GBM. So we ended up, again, Megan had just read this paper from the Sarangni lab, this FAANS et al. Paper published in 2019, where they used this mini organoid assay and got these beautiful response curves. And we thought, oh, this is great. Like, this is what we need. We're going to be testing different drugs. And so this is a assay that we adapted from that lab. And we use patient-derived samples to get dose response curves. And so here is the dose response curve to the ruxolitinib. And as you can see, that patient 1, which is Jacob, he has a pretty good response in comparison to the other patients. And also patient 23, which based on transcriptomics, we predicted they would probably respond well to JAK inhibition. They do seem to, at least on their ex vivo assay, and generating an EC50. So this was promising to us, and we're like, oh, this is really very interesting. Of note, though, I kind of told you we were doing all this work and defrosting patient samples and doing all this RNA transcriptomics. In the meantime, Jacob keeps having tumors grow back. And this is an example of his 3D predict, because I send this each time. And so this is an example of tumor 1F. And this is his 3D predict assay. He was found to be potentially a responder to EGFR inhibitor osimertinib. And so we gave him that drug. And then 2 months later, another tumor came back. I took it out. I repeated the functional assay, and you can see the EGFR inhibitor. Now he's no longer a responder. So we were getting desperate at this point. We also noticed that throughout his course that he had everolimus potential response. And there was some also genomics data that made us think, well, maybe he could respond to everolimus as well. And in the past, we've only done monotherapy. Maybe we need to think about combination therapy. So that inspired us to, I'm going to skip ahead here, to kind of look at both ruxolitinib and everolimus. And we used his primary tumor, but then we also used his last 2 tumors that I did surgery on. And we said, well, let's test on his first index tumor and then some of his later ones and kind of get response curves. And then I'll talk to the patient, talk to our oncologist, and we said, well, we think maybe perhaps we could try this in combination. And so he ended up being very open to that because, again, he's in his 20s. He wants to live as long as possible. And he ended up having the longest progression-free survival, which is 4 months, which may, again, not sound like a long time, but he was having a tumor grow within a month or 2 at this point. And so we were very excited about this work because we were able to provide some stability for a period of time. And also it inspired us to really think about combining omics data with functional data and tumor modeling. But I think also we're still analyzing Jacob's case because it really taught us a lot. So this is actually looking at his functional precision assays over time. You can see various surgical dates, and each time you can see that the tumor looks like it's changing. It's just a different tumor. And then also we did single cell sequencing. This is Dr. Liz Jancourt from University of Helsinki, who has helped us with this complex single cell analysis. And so basically he got multiple different targeted therapies. And so here in A, you can see he got CDK4 inhibition. And you can look at the expression of that pathway before and then after treatment. We saw, wow, his cancer cell population just has an increase in that pathway. That's kind of interesting. Same thing happened after EGFR inhibition, before treatment and after treatment. So we're hoping that we can use this to kind of start to understand pathways of treatment resistance. And not just Jacob, but in other patients that we have this opportunity to serially sample. And then the other thing is looking at the phenotype. So this is just an example before and after EGFR inhibition. This is RNA velocity data. You can see his cancer cell population overall before treatment seems to go towards a phenotype of a neuroprogenitor cell. And then after treatment, it seems to be going more, transitioning more towards a neuroprogenitor cell with a migratory phenotype, which again fits the picture of how his tumor became more aggressive and started moving throughout his brain. And then lastly, this is Dr. Wardell, one of my other collaborators from biomedical informatics, doing phylogeny on all the various tumors. I think we had about 10 or 11 tumors from Jacob, looking at the clonal evolution throughout time. And so we do see that all of these tumors come from, one, you can see the events that happen over time, and these aren't different tumors. They're all are related to each other, but the clones, different clones were able to compete out. And eventually this clone E was able to really outcompete the others. Again, I am a surgeon, so I'm highly biased, but I really think surgical tissue provides opportunities for unique models. This is a patient of ours with a gliosarcoma. horrible subtype of glioblastoma, and she had metastasis extracranially, so outside of the brain to the lung. We were able to get that sample and start to look at changes between the tumors in her brain versus the tumor that left the brain, and start to understand, well, how does that happen? That's a very rare event, and we can try to model that and start asking, well, how is that even possible? And then also using our organoids to look at different drug screening paradigms. Again, this is the postdoc Dr. Darig. Basically, we're very much interested in invasion. How can we model invasion using organoids and then develop different drug targets? And then Dr. Urbaniak, also a very talented postdoc in the McNichol lab, using a very advanced model called the glyco model, where you actually generate from stem cells a mini embryoid brain and then actually add tumor cells. And that glyco model is from Dr. Linkus at Vanderbilt. So we're very excited to try to replicate some of these more advanced models. But I do think practicing in Arkansas, it always comes to mind health disparities. So for me, this is a paper of ours where we were looking at just profiling brain metastasis. But as you can see, we know this clinically. If you don't get post-op radiation, you die faster. You can see how terrible that curve is for those patients. They're well under a year if they don't get post-operative radiation. And so that's why we've started to think about, well, for some of these patients that are rural and at risk for never getting radiation, maybe we need to start thinking about intraoperative radiation for them. So again, it's not just genomics and transcriptomics is really exciting, but we also have to think about where you practice in their different circumstances. So what are the future directions? I really think that real-time diagnosis is coming. I think that that's especially in brain tumors where you're reliant on molecular markers. I also think that standardizing surgical protocols will help with reproducibilities of some of these advanced spheroid and organoid models. And then also validation of functional organoid assays in patients is needed. And then using all this data to really understand how the disease progresses and how treatment resistance develops. This is one of my favorite pictures of Jacob. He was a very hopeful person and always had a positive attitude. So I think there's a lot on the horizon for us, and I'm looking forward to being a part of that. And I also want to thank all the people who have donated to the lab, the patients and families, as well as everyone that I work with. So thank you so much.
Thank you. Thank you so much. This was just brilliant. Thank you for sharing the stories of your patients. That was really really nice to hear. All right, so we're open for questions, and maybe let me start, asking you. So brain tumors is obviously not my specialty. So how often can you actually get enough tissue that you can also do functional type characterization? Is this typically the case? You have enough for diagnosis and research, or is it just a small portion?
Surprisingly, it's pretty good because oftentimes the tumors, at least up front, are very large. So you have the opportunity to send quite a bit of tissue. It's upon recurrence that it gets a little bit harder for two reasons. Sometimes the recurrence, the volume is much smaller. And secondly, the patient has undergone chemotherapy and radiation at that point. And so you have treatment change present. And that's why it's hard to discriminate, well, what part is just radiation changes and scar tissue versus actual tumor. And that's where, again, I was trying to highlight, we have to maybe use intraoperative fluorescence or other things to try to figure that out.
When you do the intraoperative fluorescence, I'm not sure what dye you use, but does that influence like the viability of your tissue then ex vivo? Is there any issue?
No, it's not. It's a metabolic, it's 5-ALA, and it actually just gets taken up by the tumor cells, and then it just forms this fluorescent compound that we can see with 600 nanometer light, but it hasn't affected assays at all.
Interesting.
And this is interinstitutional, at least the 3D Predict. There are multiple institutions that use this dye and didn't seem to affect this ability to form spheroids.
Thank you. All right. If anyone has a question, please unmute yourself. No? So, okay, I'm going to continue. Sorry, I'm going to ask you a last question. If no one, oh, sorry, we have something in. Go ahead.
I have a question for you, Dr. Rodriguez. So you talk about these patients that kind of have poor survival, like overall, but then, you talk about the fact that maybe a 4-month extension in survival is, really a meaningful response to treatment for some of these patients. So how do you kind of frame that, especially when you're communicating this to kind of the broader scientific community that might not understand the nuance of that 4 months, from an outsider might look like, oh, okay, well, 4 months is really not significant. I guess, how do you kind of reconcile that?
Absolutely. So I think I should have probably emphasized that the average time from diagnosis to death for GBM patients is 15 months with surgery, chemo, and radiation. So you're dealing with a disease that very likely your patient is going to live less than 2 years. A lot of if you look at targeted therapy clinical trials, they usually look at progression-free survival as a paradigm of how well that targeted therapy worked. And that's even in leukemia or solid tumors. So progression-free survival is kind of a paradigm we use. So when you saw the 3D Predict Kaplan-Meier curves and you saw 11 months versus 7 months, what that means is, so for GBM, the tumor is always going to come back, or pretty much almost always, and sometimes they die from another reason. The average time to come back from your primary is 6 to 9 months. So in those patients that their tumor is not coming back until 11 months later, that's actually significant. So again, it's all in the context of the disease process. The second disease that I highlighted was brain metastasis. If you look at different cohorts, and again, this is changing now in the age of targeted therapy, but classically, someone diagnosed with brain metastasis will on average live maybe about 1 year. So depending on the cohort. So again, this is a very different, malignant brain tumor world is very different than some of the other cancers where you're like 5-year survival. You're rating things on a 5-year scale. We don't have that opportunity. And then for Jacob, that was just one point in time that he got progression-free survival of 4 months. But if you look at his overall time, he was getting recurrence within 1 to 2 months. His tumor would come back. So for him, I think it's very patient individual. For him, 4 months stability was actually good, because if you remember, I did his surgery, he had chemo and radiation, and within 3 months, he already had recurrence.
Hi, this is Chris Kemp calling. I have a question about if you have drugs identified that are not FDA approved for the tumor in question. How do you get those drugs, and how do you get them paid for? What's been your experience there?
So that I haven't even clinically really broached non-FDA approved drugs unless it's within a clinical trial. So I think like if you're part of a clinical trial and it's non-FDA approved, then I think there's opportunity and phase 1 trials, et cetera. But outside of that, I think a non-FDA approved drug would be difficult. An FDA approved drug for another cancer or tumor type that you're just using off label, that the way we approach it is sometimes we reach out directly to the company. A lot of times we do that. And sometimes our cancer center has also been very nice that sometimes they have extra drug and they're willing to just give it to us. So we've been kind of lucky with the scenario of FDA approved, maybe for another reason, but we're using it off label.
Great, thanks. Congratulations. Thank you.
Mm-hmm.
Well, we are already at time. So again, thank you so much, Dr. Rodriguez, for sharing with us your research. That was really interesting. And yep, we're going to see everyone back in a month. Thank you again. Bye.